Okay, so I just want to say good day to everyone joining the last Revives webinar for 2025. We will start today's seminar with a Revive study update presented by one of our co-PIs, Dr. Sean Wasserman. So Sean, over to you.
Thanks, Elsa. Hello, everybody. So this is the tradition that we have that we just give an overview of the study, its design and study progress for people that aren't involved in the Revive network, just so that you know who we are and what we do. So this is the trial that we're speaking about. It is a pragmatic, multi-center, double-blinded, placebo-controlled trial that is evaluating azithromycin prophylaxis for people with advanced HIV disease. And in the trial, we define this population as having a CD4 count less than 100. The hypothesis underlying this trial is that people with advanced HIV and very low CD4 counts are still have an unacceptably high mortality. And we think that this mortality is driven by severe bacterial infection, and therefore azithromycin prophylaxis may be protective. So adults who have HIV, have CD4 counts less than 100, and are not acutely unwell are randomized to receive azithromycin 250 milligrams a day or placebo for 4 weeks. They followed up for a total of 48 weeks, but there's a primary outcome in this trial of all-cause mortality at 24 weeks after entry. Importantly, these interventions, the active azithromycin and the placebo, are provided on top of whatever normal care these patients are getting in their clinics. So even if they're getting cotrimoxazole, they'll get azithromycin or placebo on top of that, and of course ART. Next slide. This trial is powered to require 8,000 patients to answer this question. And so therefore we need a lot of sites across sub-Saharan Africa. Currently we have 11 sites that are 11 countries that are actively enrolling with 56 active sites. And we're planning to have 13 countries and 64 sites in total. This will hopefully happen in the next few months. But those 11 countries and 56 sites, next slide, are doing tremendously well. We have now randomized over 4,100 individuals into this trial out of, as I said, a total of 8,000. So we have gone beyond the halfway mark. It's a huge milestone for us, the entire trial, and a huge achievement for all of the investigators that are working on this. The combined number of patients that are enrolled every 30 days across these 56 sites is close to 300. So an enormous undertaking and a fantastic achievement. And you can see here that all of the sites are contributing patients every month, which is very gratifying to see. The colored column shows the number of participants that are potentially lost to follow-up, and you can see this number is incredibly low for a trial of over 4,000 participants. Next slide. So you can see that differently in a graph here. The blue line is the projected enrollment, and the purple line is the actual cumulative enrollment. And you can see that we are exceeding our targets. And at this rate, we should finish the trial early, get fully accrued early, and be able to answer this question as soon as possible, which we think is vitally important. So that's all I have to show before Prof. Ansong speaks. And I just want to again say thank you to all of the investigators on Revive for incredible work that you're doing. Over to you, Elsa.
Thank you, Sean. So there's just one housekeeping rule that I want to bring to everyone's attention is to please keep your speakers on mute. You are welcome to pop any questions in the chat box throughout the presentation, or there will be a 10-minute question and answer session at the end. So today we are honored to welcome Professor Daniel Ansong, one of Ghana's leading clinician scientists and a highly respected global research collaborator. Prof. Ansong is a professor of pediatrics at KNUST and former dean of both the School of Medical Sciences and the School of Medicine and Dentistry. He has also served as Deputy Director of Research and Development at Komfo Anokye Teaching Hospital. He has played a central role in malaria vaccine research in Ghana, serving as co-principal investigator on all the phase 2 and 3 malaria vaccine clinical trials, and as the safety lead for the WHO Malaria Vaccine Implementation Program. He also contributes to WHO's global surveillance programs for pediatric sepsis, meningitis, and rotavirus diarrhea. His current portfolio includes leadership roles in the NEPS Adolescent Mental Health Study, the SMART Severe Malaria Consortium, and he serves as a co-investigator on the REVIVE study in Ghana. So please welcome Professor Daniel Ansong presenting on malaria and HIV in sub-Saharan Africa.
Thank you very much, and good afternoon to you all. Just a moment as I share my screen. Right, so it's a privilege to come on board to share my experience and knowledge on what it is in malaria and HIV in sub-Saharan Africa, what it is in the academic arena on this subject. I'll look at why malaria and HIV matters, mechanisms that are leading to complicated malaria and HIV patients, malaria and HIV historical review, what has happened within the past, current burden of the disease, malaria and HIV, and to be specific, malaria and HIV infection in the risk group that we have been working on even in our REVIVE study, some impactful malaria and HIV interventions, future outlooks and recommendations, and some takeaway information. Right, so we know malaria is a parasitic infection caused by P. falciparum, 5 species, but the most important species is the P. falciparum, which causes the most severe form of malaria in children less than 5, in pregnant women, as well as in those who are not immune. It causes huge morbidity and mortality. HIV/AIDS causes chronic infections, reducing immunity of individuals. When these two diseases come together, we would find from evidence from several clinical studies and trials that have shown that the co-infections with the disease both disposed to affect the vulnerable. The pregnant woman, children, and people living in rural areas, people living in areas with poor health systems, co-infections usually leads to bad outcomes. Estimates from malaria and HIV reports that there's about 19% and 26% have been found in non-pregnant, non-adults, 12% in pregnant women, and 9% in children. Now, what are some of the proposed mechanisms that leads to the complications that we see when we have malaria and HIV? The impaired cellular and humoral immunity leads to higher parasite densities. It's been recognized that HIV causes CD4 T cells loss and broader immune dysfunction, reducing the ability to control P. falciparum infections. This, in its essence, would increase higher parasite densities and more frequent clinical and severe outcomes. Severe outcomes that are known to us are cerebral malaria, acidosis, renal failure, and other multi-organ failure cases that we see. We've also seen evidence of blunted antibody responses to malaria antigens, where HIV-infected patients show slower magnitude and narrow broad antigen response to merozoites antigen, impairing opsonization and parasite clearance, a mechanism that is linked to more severe disease formation. The splenic dysfunction and impaired parasite clearance that occur within the spleen is also one of the pathways that makes the co-infection one of the issues that we would always have to come across with. It's been found out that there's increased anemia and hematologic vulnerability. HIV patients have HIV/AIDS have direct effect on opportunistic infections, nutritional deficiencies, marrow suppression, and it increases the baseline anemia risk, and malaria further worsens their situation. Again, in pregnancy, the specific synergy, increased placental parasitemia, there is a positive increase in peripheral blood as well as placental parasite densities in patients with HIV and have malaria at the same time. These specifically affect pregnant women as well as the growing fetus. Growth restriction, neonatal complications are some of the issues that have been reported in several articles and research work that has been done. A bidirectional viral parasite effect worsens clinical course and increases the viral load. So acute malaria episodes may transiently increase viral load in HIV patients and can accelerate immune suppression and create a lot of problems for these patients. What has been found, and I'll show a slide that to show drug-drug interactions and treatment complications that potentially can occur. Again, delayed care, comorbidity, burdens, and social determinants that I show a slide by a recent Lancet paper, how the social determinants and the comorbidity worsens the clinical situation of individuals with HIV/AIDS infections. The historical overview. In the last 140 years and over, we have been with malaria, and there has been several attempts to be able to control, to eradicate malaria in several countries. Some have been very successful. In Sub-Saharan Africa, the transmission is still there, it's real high, causing enough burden. In 1939, when DDT was introduced to control vector, even though DDT was also found to be a very dangerous chemical that can also worsen environmental pollutions. We moved to chloroquine in 1961, and fast forward, we currently have the artemisinin ACTs being recommended by WHO as a drug of choice for the treatment of malaria. Within the last 20 years, when RTSS vaccine also came in, and R21 vaccine, two vaccines that have been deployed in Sub-Saharan Africa as additional tools for the management or control of malaria, they are all showing promise for a potential decline. And I will be showing a slide that you would see the decline in the new tools, which would potentially cause further decline in the parasites circulation as well as disease burden within the country. HIV since 1980, when it was identified through 1990, when cases came out, WHO gave recommendations, has also gone through several phases of interventions and programs aimed at reducing the disease on mankind. And you would realize that within the last couple of years, there are very important landmarks activities that had come on, for instance, in 2023, where people who lived with HIV achieved undetectable levels was one of the landmarks. And at the end of 2022, around 29.8 million of the 39 million people living with HIV were taking antiretroviral drugs. And that was one of the things that the world needed to do to be able to reduce transmission, to be able to improve care for those who are living with HIV. Now, the Global Burden of Disease Program database has very important data that it's interesting to see. This data has been analyzed and published in two important publications for the past 30 years of the disease HIV, AIDS, and malaria. And between 1990 and 2021, these studies show that based on key factors, age standardized incidence rates, age standardized disability life years, age standardized mortality rates. And this has been stratified by gender, religion, age, and socio-demographic index. The analysis was based on per capita income, educational attainment, and fertility for the socio-demographic index estimation. Now, this is the trend currently for the past 30 years, 1990 to 2021. The trend in age standardized incidence rate, the global trend you would see slowing down and being stratified under high socio-demographic index, high to middle, low to middle, and lower. You would see at least a decline in this. But the sheer numbers of patients that we have in Sub-Saharan Africa still makes the disease of public health importance and need to always pay attention to this disease and work through it. Again, the Global Burden of Disease database shows age stratified distribution for incidence, for disability adjusted life years, and for mortality. And you could see between the age range of 24 to 54, we would have the burden of effect in there, irrespective incidence, mortality, and disability we'd have in there. Again, when you look at gender, comparing females and males, the females are always, because of their vulnerability, biological vulnerability, as well as the social demographic disparities that happen, we tend to have a higher burden in females and males for incidents, for DALI, as well as for mortality. This gives a summary of what we know for 2024, looking at people living with HIV, people acquiring HIV, and people dying from HIV, and a total of 40.8 million people living with HIV that was estimated by WHO, people acquiring or people who acquired the disease, around 1.3 million, and people who dying from the disease, 300 and 630. The last row that is looking at children less than 15, we have 1.4 million people living with children living with HIV, and those dying around 75,000. And so if you are in HIV patient and you're living in a malaria transmission area, your risk of getting malaria and your risk of dying or developing severe morbidity and mortality is very high. And it's very important for us to pay attention to these figures, because the sheer numbers of these figures still calls for public health interventions and other interventions to be able to control this disease. Pictorially is shown in here how the decline is going, but there's still more to be done to be able, because if you have an estimated 630 people who will be dying from HIV, that is a huge figure that we need to pay attention to. In summary, for the HIV, we have 48 million people who are living with HIV, and 1.4 million are in children 0 to 14 years, and somewhere around 39.4 million adults 15 years and above. The incidence declined per the graph was shown by 18%. Sub-Saharan Africa still remains the highest. That is why more efforts should be placed on the interventions that are coming to South Africa. It has been found that Burundi and Burkina Faso have shown a significant progress based on the social interventions that and improvement in health systems that they have put in place, and they have gotten some very good results in there. Unsafe sex remains the leading risk factor for HIV-related DALI that's been reported. Now, regarding malaria, the malaria in the last 20, 30 years, the estimates were a child dying every 1 minute. Now, this picture is also slowing down, and this trend gives us some assurance that additional efforts being placed in malaria interventions and tools to fight malaria can potentially help to further slow this figure down. So if you look at the global picture versus the low socio-demographic index and low middle income, you could see a decline, a remarkable decline in almost all the social SDI structures. However, there's still more to it. In terms of some peaks, post-COVID-19 era, there were imbalances in challenges in distribution of anti-malaria drugs, testing and treatment, and all those factors really affected malaria control. And there was some rise in incidents in malaria, which potentially affected the programs, but there's still more promise. Now, Lancet in March 2024 published an article uncovering HIV and malaria interactions, the latest evidence and the gaps. I would recommend that colleagues find this article and read an interesting article that has very important information for us as we think about malaria and HIV, the co-infections, because the interactions, apart from its having effects on individuals, it's the public health effect is affecting the control of the disease. This map is showing the transmission of malaria with also HIV, people living with HIV in 2020 and superimposed in the 2022. So for instance, if you look at people living in HIV in the Caribbean and Latin America, the point estimate is 2.6 within an interval of 2 to 3. When you come to Western and Central Africa, 4.8. When you looked into the Eastern and Southern Africa, it's gone up to 20.8 as And when you get into the Asia and the Pacific, there is also a constraint. And if you look at all these areas, the areas where malaria transmission also exists, and it brings attention to the fact that when you have these two very important diseases coexisting, there's a need to pay attention to it. Now, looking at malaria and HIV co-infections, this circle that is showing malaria up, HIV down, and the three most important factors to look at, social and economic factors, geographic factors, and biological factors, all coming together, should be our targets for addressing the burden or the double burden that we have with us. Now, on your right hand, you would see four main areas. The effect of the interaction between malaria and HIV. The co-infection alone would increase severity of illness. Causes or cases of cerebral malaria increases. Cerebral malaria is one of the diseases that causes high mortality in children less than 5. It's used to have a mortality of about 25%. 1 in every 4 child who comes with cerebral malaria is likely to die. Increased mortality. Possible drug interaction effects. Now show the chart on drug interactions which clinicians would pay attention when they are managing patients with malaria and HIV. The co-infection in pregnant individuals increase adverse birth outcomes. Low birth weight, stillbirth, fetal growth retardation are some of the birth outcomes that are not desirable. There's an increased maternal mortality, neonatal mortality, decreased antibiotics against placenta type parasitemia, and so even the placenta parasitemia has effect on the newborn. Then when you come to the effect of malaria on HIV, there's increased viral load, decreased CD4 count, increased production of interleukin, interferon gamma, and other inflammatory cytokines. There is a possibility of increased vertical transmission. Then the effect of HIV on malaria, risk of infections, increased parasite density. When there is increased parasite densities within the communities, then transmission across communities would also be either maintained or be increased, jeopardizing the need or the call for elimination of malaria. Now, this slide is a very busy slide, but I would plead that we pay attention to this publication that Lancet had carefully actually looked at several studies that are looking into cross-sectional studies, descriptive and meta-analysis, trying to give us enough evidence to show that malaria HIV co-infection has effect on the patient. And potentially the parasite transmission issues, viral transmission issues can disrupt any attempt to control the two diseases that we have. And there are about a dozen and over articles that have been carefully been summarized to look at the interactions that have been described. And I show this as a very important information for our academic use. Again, the drug interactions between antiretroviral and anti-malaria are very important. What it is that we need to know. First of all, clinicians would have to pay attention that when you have a patient with the co-infections and you are managing this patient, then potentially studies have found some drug interactions that you would need, reducing the parasites, the amount. So for instance, nevirapine and amodiaquine, there's a possible decreased plasma concentration of amodiaquine. With artemether, there's also a decrease in concentration. With artesunate, there's a decrease in concentration. In some still studies are inconclusive, but whatever this slide is showing is that there is a potential for reduced anti-malaria effect and vice versa for patients that were given co-medications and therefore should be able to pay attention to recovery and test parasite clearance as you manage your patient to be sure that the patient has cleared the parasite, because as you have parasites within the mind, evidence have shown that it also disrupts the virals and increases viral load in our patients. The future outlook of the disease. The RTSS vaccine in Ghana, it has been deployed across the country, and children 5 months and above are receiving the vaccines. This is an additional tool on top of bed nets, on top of seasonal malaria control programs, on top of post-malaria discharge chemoprophylaxis. This is being instituted. There is a need for this recommendation by WHO to be carried out by Sub-Saharan African countries where transmission is very high, for malaria is very high, and HIV also exists. This tool can potentially help improve the health of patients with HIV and who may have come into contact with malaria parasites. There will be a need to do a genomic surveillance on how these vaccines are working on the population, as well as use digital tools to improve on data to be able to analyze trends in response to additional tools that have been applied. Again, HIV, long-acting ARTs and PrEP interventions are very important tools that are also very good, that African countries that have not enrolled this should probably be looking into it, especially preventing disease among adolescents, and also gender-sensitive programs should also be considered as very important tools to use. There is the urgent need to scale up the availability of long-acting ARTs, especially in Ghana, where I'm coming from. We have not gone into it, and therefore I would urge other African countries that there's a need to begin to talk about it, to see how to, especially where stigma continues to be a problem with adherence to treatment. Again, there should be obviously be a combined integration of antenatal care practices that looks into preventing malaria and HIV, TB, and making sure health services systems are efficient in their management. Now, I've said some of this already, but there has been impactful malaria intervention programs that obviously have brought us to this level, but there's still the need to push more to be able to get eradication of the disease. Now, malaria, DDT, insecticide-treated bed nets, ACTs, RTSS are very important success story for the control and elimination of malaria. And it is a recommendation that individuals or countries still promote ISTNs, ACTs, and RTSS or R21 vaccine in their region. This would reduce transmission, this would reduce morbidity and mortality, and this would also improve the daily of individuals within the communities and the society. Now, again, when you look at HIV impactful programs, the PEPFAR program in 2003, the introduction of AZT in 1987, and HART somewhere between 1990s and have all made very significant impact. And I believe our effort to reduce the disease morbidity and mortality, that is what is even taking us into a revived study that we potentially have. If results are very successful, it will become one of the tools to look at those who are having CD4 count less than 100 and are critically ill and we need additional support to be able to stay well with their disease. We have the 3x5 initiative by the WHO, the pre-exposure prophylaxis, also another important program that also has been very impactful in the HIV intervention, and the current long-acting injectable ARTs are also very important interventions that are coming in that countries should begin to work around to get these as part of the tools to control, manage, and prevent HIV. My short recommendations will be scale up and sustain core interventions to insecticide-treated bed nets, indoor residual spraying, ACTs, artesunate solution, and then post-malaria treatment, chemo treatment, also very important. The RTSS vaccines in Ghana, I know it's one of the government's priority, and so it's giving out 21. Other African countries have also begun to use it, and it's very important. These tools would help reduce the episodes of clinical malaria, episodes of severe malaria, then also potentially reduce transmission as well. We need to strengthen and integrate services for both ANC, community platforms, and surveillance, such that the two diseases should not be seen in isolation, but to be put together in every public health planning and intervention. Obviously, there's the need to invest and implement science and equitable financing to be able to work, find more evidence, look at trends of diseases to be able to manage. We need to leverage on digital health and genomic tools for smarter programs that we're currently entering into it. My take-home message will be malaria and HIV remains high priority for South Africa, Sub-Saharan Africa. Vaccines and long-acting preventable treatment tools should be the new opportunities for us to embrace. Integrating across health systems and communities should be one of the priorities to maximize the impact and sustain investment. Budgets by government should look into health innovations, and political commitment is very critical. Sources of information were from WHO, Nature, UNAIDS, Lancet, and the Global Burden of Disease database. Thank you very much.
Thank you very much, Prof. Ansong. I would like to open up the floor to anyone who has got questions, who can pose it to Prof. Ansong now. I just wanted to let everyone also know that with Prof. Ansong's approval, we will also post this to the Revive website, and the recording will be available to anyone who would like me to share it with them. There's a question from Stephanie from Wyk.
Good day. Thank you so much for a fantastic and insightful presentation. I work in malaria and the anti-malarial drug resistance field. Much of Eastern Africa, and there are some concerns in southern parts of Africa that there's drug resistance against some components of the ACTs. So the idea is that much of these regions will move over towards multiple first-line treatment. And I'm wondering if this information is taken into account when considering these drug interactions. Thank you again for a great presentation.
Right. So I'm aware the emerging resistance is of great concern in the eastern part of Africa, and the proposal to look at triple therapy, where in addition to ACTs, a third medication is being added. I did not check on the recent publications or recent findings on the clinical trials that were going on regarding the triple therapy for combinations for malaria, but it's on the World Health Organization's high agenda to look at what are the options for addressing the emerging resistance in Sub-Saharan Africa. The potential for triple therapy, it's one of the things that is being considered strongly. Thank you.
Stephanie, any further comments or questions from you?
No, that was very good. Thank you so much. Maybe if everyone won't mind, I might drop some literature in the chat. Maybe that will for further reading. I don't know. Thank you.
Thank you. Appreciate it. Questions from anyone else? I don't see any more hands. I'll give it another minute or two. Okay, it seems like there's no more questions. Prof. Ansong, a very special thank you for your time today and for your insightful presentation. As I said, I will make contact with you just to get your permission to share this with the wider Revive network via our website, and also share it with everyone who wants me to share it via email can just pop their email address in the chat. And then I just want to say a very special thank you to everyone for the continued support in attending all the 2025 Revive webinars. The first for 2026 will be on 28 January, and it'll be on HIV-related cardiovascular disease in Africa, and it'll be presented by Prof. Mpiko. And then lastly, from the Revive team, just wishing you all a very special festive season and a great week ahead. Thanks for attending.
Thank you very much.
Thank
Thank
you very
you.
much. Thank you.